I have the honor of officially welcoming everybody to our third annual Global Virtual Cancer Conference, or GVCC. I am David Craig, two-time cancer survivor, one of the founders of Gryt Health, and our CEO. I have the honor of being the first voice in this event, but you will see as we go through the next 3 days that it is your voices that are the most important. When we started this event 3 years ago, it was because of our personal experiences, the needs and the things that we each wished we had as patients and caregivers. But it has grown now over these past 3 years to be so much more than we ever imagined, because of the more than 7,000 people now from around the world who have joined us. Thank you to each and every one who makes this possible. In 2019, we started this event with a single day. In 2020, we added a second day. And this year, we're adding a very special third day, which you are a part of right now. Today, we'll focus specifically on patient and provider communications, something that many of us, myself included, were never really trained how to advocate for ourselves or improve those conversations. I'm deeply honored for that to start shortly. This is truly more than a cancer conference, more than a healthcare conference, and more than a patient education conference. GVCC is truly a humanity gathering. By joining together with all of us as attendees, we are harnessing our united grit to tackle the issues, the real issues that we face when talking about cancer. We're going to talk about topics that matter. Content around genetics, treatment breakthroughs, patient advocacy, managing our long-term side effects, relationships through cancer, and so much more. We will tackle content that is often really hard to discuss, including metastatic diagnoses and health inequities. We will hear struggles and we will hear miracles, and we will all see what it means to find and to use our voice. These are going to be courageous and they're going to be necessary conversations. It is our greatest hope together that this event helps us turn what made each of us feel powerless in the face of cancer into having power. That we can find courage by seeing others find and use their voice to talk about topics we might not have ever thought we'd have to talk about. And ultimately, to take what might have made us feel hopeless and find hope. I'd like to take a moment before we get started to thank everybody who has brought this event to life. Each of my fellow Gryt Health team members are cancer survivors, caregivers, advocates, healthcare providers, researchers, and so much more. Although each of our journeys is unique, it is the shared experience of cancer that brings us together and fuels our relentless passion. In many ways, this conference is the resource that we wished we had and didn't when we were going through cancer. 3 years ago, our chairwoman and my friend, Shelley Nolden, came up with the idea for this event. It was because Shelley, who was inpatient for leukemia, was trying to do her laps around the hospital while not able to walk very well. She saw a poster on the hospital wall for an in-person event and felt heartbroken because she knew that she couldn't attend it. It was out of her reach. And so we approached our founding partner of this event, Bristol Myers Squibb, with an innovative idea to create this virtual conference to bring resources to patients, caregivers, and advocates wherever they are, regardless of what situation they're in, regardless of geography, financial limitations, treatment status, where we are in our journey, and everything else we go through. It is because of these sponsors and our partners that we're able to make GVCC a reality and connect thousands of people to information, to experts, to our peers, and to help each of us find and use our voice. I know that each conversation I'm a part of, I learn something new about others and I learned something new about myself. I'd like to thank Kathy Traz and BMS for believing in this when it was just an idea and continuing to support us every year to bring this event to life. Thank you to Mariah Morris and Anna Pachenik for being the champions of creating it this year. And thank you to everybody at BMS and all of the stakeholders who have brought their expertise and their passion to co-create what we're starting tonight. I want to specifically thank all of our sponsors and partners, including our flagship sponsors, Amgen and EMD Serono, our thought leadership sponsor, Deep Lens, our empowerment sponsors, Syneos Health and CGen, and our media sponsor, Cure. It is because of these sponsors and partners that this event is no cost, not just for the community, but also for all of the advocacy organizations and exhibitors whose resources you're going to interact with. And of course, a huge thank you to the nearly 50 nonprofit patient advocacy partners who have created dedicated spaces and filled them with resources to help everybody gain access and manage or navigate your journeys. Also this year, we've renamed our clinical trial fair to be the Research Launchpad. It is an area in this virtual conference where you'll be able to find organizations who have information about current clinical and other research opportunities, as well as how to help navigate that really confusing space. I also want to take a moment to recognize that in the United States today is Veterans Day, and to say a very special thank you to all of our veterans and military families, myself and many of our team members included. Thank you for your sacrifices and thank you for everything you do. Also in the US, this is National Caregiver Month. Caregivers are often the unsung heroes, and we want to say a special thank you and welcome for the caregivers who were with us. We're excited for sessions for you to join and be supported as well. Okay, are we ready? I now have the honor to introduce and kick off our very first session for GVCC21. This session is focused on balancing our humanity, specifically designed for those who work with patients like us in clinical settings. This session will be led by Aaron Donovan, PhD, and Kat Holland, MBA, BSN, RN. They are going to take us through a live role-playing session to talk about effective patient and patient and provider communications with a focus on empathy, active listening, and perspective taking. I now have the honor of handing the mic to Aaron to lead us through this workshop. Please help me welcome Aaron.
Hi, thank you so much. Thanks, y'all. It's wonderful to be here. David, can you hear me okay? Great. Kat, I'm actually looking at you via Zoom and wondering, did you want to start us off?
Yeah, that would be great. Hi, everybody. I'm Kat Holland. I am coming to you from Rochester, New York. I'll give you a little bit about my background. I grew up in a cancer family. I had a sister when I was 7. She was 4. She had an astrocytoma. And a lot of our, our family life really centered around making sure that she was okay and that cancer care. And I had the privilege of going to cancer camp when I was little. I went to a camp called Camp Good Days and Special Times, really my entire childhood and my adolescence. So I definitely would qualify myself as a caregiver in the cancer space. I actually grew up to go into nursing. My background in nursing is in psychiatric and community health nursing. I've always had a love for the human spirit and really connecting with folks who aren't used to being seen or heard. I feel like that is really a gift that we give ourselves and give to each other. So just wanted to give you a little bit of background about myself. The last 10 years or so, I've been in hospital leadership. I work in the acute care setting. I'm currently a vice president for care management at a health system in Buffalo, New York. And I do still spend about 20% of my time seeing patients. So it's really important to me in my leadership role to still stay connected with patients and families and just remind myself, why we're all here and why we're doing this. So when I was asked to, share some of my expertise or share some of my experience at tonight's conference, I realized that at first, of course, I'm very, very excited to be here. But then I also got kind of nervous. I feel like over the last 18 months, I've been kind of living under a rock, right? I'm working in the acute care setting. We've gone through layoffs, furloughs. My health system had a workforce strike. We've had COVID, obviously, has just been incredibly intense. So, it is such an honor and a treat for me to be here tonight talking about something that, it's just so deeply embedded in my heart, but I feel like I haven't necessarily really had the luxury of talking about something that's therapeutic. And I'm just really, really grateful for the opportunity. So thank you for having me here and talking about something that's really near and dear to my heart. It's such a great reminder. I don't know if any of you have felt like you've been living under a rock, but I'm glad to be coming out of it tonight and to be here with you. So this slide, I think that we could have, many more kind of lines of people here, right? We've got a line of patients. I'm speaking from the provider perspective. It always seems like there are, a ton of people who need care. I'm seeing people in the acute care setting that are sicker than before, folks who really held off getting testing or healthcare maintenance because of COVID. So when they're finally seeking care, there's an increase in symptoms, there's an increase in the severity of the symptoms, and an increase in anxiety, quite frankly, just in the entire population. So I feel like not only does it seem like there's more people, it seems like the folks that we're seeing are really honestly sicker. At the same time, there's less staff. There's been a lot of staff turnover. There's been a lot of just folks who are getting out of healthcare because of the intensity of the situation, following different dreams, just moving on. So in this picture on the right here, the person, the clinician with so many arms, truly so many days, that's really what it feels like. Last week for 4 hours in the evening, I actually worked, when I was done seeing patients, I worked and helped deliver dietary trays because we're just so short staffed. So I think that we're, all over our health systems, all over our communities, people are really, pulling out all the stops to make sure that folks are still cared for in a really compassionate, caring, quality way, but it certainly hasn't been easy. And then on top of that, of course, we still have patient experience measures we're worried about, key performance indicators, right? Quality indicators. So it's juggling a sicker patient population that we're really getting to know with all of with the demands of a high functioning health system. And then not in this picture is our families, right? And all the responsibilities that we have outside of the healthcare setting. So I can speak for myself and just share that it's really felt like an awful lot over the last, 18 months or so. So, of course, tonight we're going to talk a little bit about empathy and authentic connection. And I love this picture because, just talking about the previous slide and all of the responsibilities and the kind of the chaos and the intensity that goes along with that. And then we shift over to empathy and authentic connection. And there's always this perception that we have to do it perfectly, that empathy and authentic connection, really, you have to be zen, you have to be completely present. It might work for somebody who isn't as busy as I am, or who doesn't have as much chaos or frustration, let's say, as I do. So I think it's just really important that we just recognize that empathy and authentic connection, we don't want it to have to be something that's separate than who we are, or that we have to be perfect for. So I think as we go into the conversation with Erin later, we just remember that we're all imperfect. We all have a lot going on, and that we bring our imperfect selves into these authentic connections, and muster up whatever empathy we have left at the end of the day. So, and that's what we're bringing to the table. We're not bringing 10 hours of meditation and perfection to the table. I can speak for myself that I've got a pretty intense meeting schedule. I can see up to 36 patients a day. There's days that I forget to drink water or haven't used the bathroom. I'm eating on the fly. And so I need to figure out how to maintain authentic connections, in amidst the chaos. The chaos isn't going to necessarily go away. And I'm probably not going to have, any more, my behaviors, I'm not going to be meditating during the day likely. So I have to figure out how to nurture this within myself without being perfect. So this picture I put in the slide deck because for me, empathy really reminds me of kind of like a pilot light, okay? It's somewhere in there, inside of us. It's burning slow, it's slow burn, it's a low burn. It's kind of holding the energy and the potential for what's to come. It's on all the time, it's efficient. So we can really tune in when we're going through the different conversations and things with Erin later. I really want us to focus on kind of that pilot light that we have inside of us, knowing that it's centered, it's in there, we can tune into it. We can turn it up if we need to. So when we get into the different types of empathy, I just want us to remember that inside of all of us is just this little pilot light, if you will, this potential for empathy, this potential for, holding and creating space for another from an empathetic place. So it doesn't need to be, it's not, I didn't put a picture up of a bonfire. It doesn't need to be, it can just be a small flame that we hold inside of ourselves to hold for somebody else. Again, imperfection, right? Not needing to pull out all the stops and give all of our energy to every situation. Sometimes we have to really pace ourselves to make it through the day. So overall, there's, generally speaking, there's 3 different types of empathy. There's cognitive empathy, right, where we're accurately perceiving and understanding the emotions of another. There's compassionate empathy, the ability to understand and share in someone else's emotions without taking them on as your own. And then there's emotional empathy, sharing the feelings of another person. I put the compassionate in the middle just because I feel like that's kind of a nice middle road that we might, be talking about mostly for the healthcare setting. But I do want to, let's start with cognitive. I do want to kind of call out the fact that cognitive empathy is, like we said, accurately perceiving and understanding the emotions of another. So in healthcare, I have met a lot of really brilliant, kind, amazing people who are just excellent clinicians. Their clinical skills are absolutely incredible. But their repertoire, let's say, of feelings, their depths of feelings, their understanding of feelings, their interest in feelings is actually really pretty low. They didn't grow up in a family that talked a lot about feelings or helped them identify feelings. So I think that's important for us to kind of acknowledge here, that that empathy really is a spectrum, and that some people just don't understand feelings like other people, and that's okay. But when you're looking at this feeling wheel, I would really highly encourage folks to, I got this from feelingwheel.com, to print the feeling wheel and to keep somewhere in your space, because we can we can learn feelings kind of like we can learn symptoms. So if you're somebody who just doesn't, you might have a couple of you might be able to identify some of the main feelings like angry or happy or sad or fearful. It would be really helpful in your cognitive empathy and you're connecting with your patients to really be able to identify feelings that you have and that other people have. And that can be something that you learn, just like you learn, different symptomology that go along with the different disease states. So I just wanted to put the feeling wheel here and to acknowledge that there are definitely really, really talented clinicians that don't really have don't really understand our feelings and are scared by that. So when it comes to the conversations, when it comes to role playing, sometimes that's why I find why folks avoid going there, why folks avoid asking those questions that they know is going to be kind of like the Pandora's box question, because they aren't really sure how to identify or deal with the feelings that might come out of that. So this is just a helpful tool that I found to really, help define what some feelings are. And you can get away with cognitive empathy it's good enough. It really, truly is. So if you aren't somebody who has a lot of depth of emotion, being able to identify feelings in another person and being able to hold space while they explore those feelings and while you're there exploring with them, that's enough. So I just want to reassure folks that, as we get into these conversations, that we don't, that even if it brings up a lot of emotion in another person, we don't necessarily really need to shy away from that because we don't have to own their feelings. We can just hold space for them. And then here's my pilot light again. So looking at compassionate empathy, really it's kind of a nice combination of cognitive empathy. So I understand, I'm able to identify or maybe interpret the feelings that I'm perceiving that you're having. I'm able to interpret and identify my own feelings I'm having in the situation. Maybe I can share those back to you, have a little bit of, reflection and tuning in to make sure that I'm interpreting your feelings correctly. And then the important thing about compassion is that I'm not taking your feelings on as my own, that there are some boundaries around that and that I'm able to elicit your feelings from you. I'm able to help nurture the conversation and really hold space without taking your feelings on. And from a sustainability perspective, that is, much more sustainable than going in and seeing, 20 patients, 30 patients and taking everybody's feelings on. So I think it's just, for me, compassion is where it's at. That's really the space that I try to live in when I'm working with patients and families, is being aware, but also being aware of what I'm taking on and really holding space for myself as well. I'm just looking at my notes here. The other thing I wrote down is it's relatively sustainable. So, just like that pilot light, compassion it's a relatively sustainable form of empathy that we can that people can truly feel. They can feel our authenticity, but again, we're not drowning in kind of the intensity and taking on other people's emotions. We are having our own emotions during the moment that we're able to acknowledge, but we're not taking on other folks' emotions. Just gonna. Okay, I saw the chat sparking up there. All right, so then emotional empathy. I wanted to touch on this. Obviously, this is a much more kind of consuming feeling, and this is absolutely appropriate at different times. It's much more intense. I usually, will feel. I'll usually kind of feel emotional empathy when it's close relationships, shocking events. I have to be really careful about social media and things in the media, because sometimes that can actually spark emotional empathy and being really draining for me, even though I don't know the person, or I don't, it can really be very, very draining. So I have to be careful about using emotional empathy. I have to be really sort of choosy how I use it, because I know that it can be very draining for me, and that I usually reserve that for, intense situations where people who I'm close to really need a lot of intensity from me. Now, this is, when I talk with my colleagues, and when I've talked about empathy in the past, I get the sense that this emotional empathy is kind of what people think about when you say, oh, you need to come into a situation with empathy. When Erin brings up her, her topics later and her suggestions for kind of opening Pandora's box, I get the sense that clinicians and providers often think of needing to have emotional empathy for when these topics come up. And I would just challenge you to really tune in with yourself as you're meeting with folks, as you're sitting with patients and families going through absolutely incredibly difficult decisions and discoveries, and recognize if you are really sort of taking on the weight of the world with what they're sharing, or if you're able to be there and hold space for what they're sharing, and really allow folks to have their own experience, and being aware of the experience that you're having at the same time. Any, emotional empathy, compassionate empathy can feel intense and overwhelming at times, but for me, emotional empathy is definitely typically pretty darn intense, and can be overwhelming if you're experiencing it over the long term. And then I think the other important thing to talk about when we're talking about empathy and we're talking about compassion, are boundaries and holding space. And, again, I think boundaries are, it's an interesting word. A lot of times when we think of boundaries, we think like, you stay over there, I'm going to be over here. I want to make sure you're separate from from me. And I think that I want to challenge us to think a little bit differently about boundaries. So I don't know if any of you have ever done this, one of these lanterns that's in the picture here, but last year I had one of my friends was wanting to release some things that weren't useful in her life anymore. And so we both bought these lanterns, little tiny flame, just like a pilot light. And I'm sitting there and I'm thinking, this isn't doing anything. I think mine's kind of broken. It's not really working. This is going to take forever. This flame is going to catch the paper on fire. And I can often feel like that, honestly. It's kind of an analogy sometimes for what I feel like when I'm working with patients and families that are on a journey. Sometimes I'm thinking more about doing. I just want to fix it. I just want to get the conversation going. I just want to move it to a place where I think it should go. Maybe it's taking too long, to be honest. Maybe I'm just not in the present moment. And before you know it, really, if you hold the space, just like this lantern is holding the space for the warmth, it's holding the space for what that flame, that tiny little flame, is meant to do. I think that's kind of what boundaries are. We set the boundaries. We hold ourselves safe inside of our boundaries. We have our flame of empathy. We hold the empathy, and we just allow the experience to transpire, trusting and knowing that if we're holding space in a loving, compassionate place, that it will unfold in the way that it will need to. And people really truly feel that. They feel that. They don't, I've never really gotten the feedback that, some would prefer me to have more, all the answers. I think that, overall, people want to feel heard. They want to feel understood. They want to feel like you really are taking the time to hold the space for their worries, their concerns, their questions. And so I think boundaries help with that. And I think that it just really does help us to hold space for patients and their loved ones, and allowing it to take time. And interestingly, with the right questions and the right setting, taking time, doesn't mean hours, right? We've all got limited time. I think Aaron will probably get into that, but it doesn't always take, 5 hours to get something moving with the patient and family. You can really do it in a meaningful way relatively quickly. This is my last slide, and then I'm going to turn it over to Aaron, and we'll continue with the dialogue and the conversation. Self-care and self-connection. There's 101 ways that we can care for ourselves, right? Eating right, exercise, sleeping, meditation. The couple of things I just want to call out that we can do in the moment is when we're meeting with patients and families, really focusing on where our feet are, planting our feet on the ground, focusing on our feet, really rooting ourselves, grounding ourselves, coming into our bodies, holding that space in our bodies, paying attention to our breath, right? Is our breath shallow? Are we kind of holding our breath? And then paying attention to our hands, our jaw. Sometimes I'll actually find myself kind of holding a fist, clenching. I forgot to breathe. And I'm kind of going out of my body because I'm thinking of the next thing that I need to do. When really the person that's right in front of me is the most important. So that's really what I have to kind of offer to the conversation tonight. Just wanted to set the stage for really moving into the role playing and moving into some of that higher level thinking around how we approach some challenging conversations when we might want to shy away. Yeah, and somebody, before I hit mute, somebody did put in the chat, and good listening skills. Exactly right, Leona. I think that, that's what we're really holding the space for, is being present to listen to the other person, both listen to what they're saying and listening to what they're not saying. So I think that's where, that's where the conversation is going to go tonight, is really how to develop those listening skills and those eliciting skills.
Well, I'm delighted to be here, and my name is Erin Donham. I'm a faculty member at the University of Texas at Austin. I specialize in interpersonal health communication. I am the Center for Health Communications expert on difficult conversations, and I'm so pleased to have this opportunity to get to know y'all in this very brief time and share some insights from research that really bolster and add to what Kat was sharing with us. So I really appreciate the start and the segue. I will encourage you to use the chat as much as possible. I'm going to run through a ton of information, just giving you some snippets, a taste of what we see from the evidence base on health communication related to some of these challenging communicative moments. And I would love for y'all to be able to trade ideas with each other and really learn from experience, because there's so much that you bring to this. Okay, there we go. So I'm going to talk about how a lot of this from a communication perspective counts as work above and beyond the good work that y'all are already doing, and talk about some coping and communication strategies that hopefully can help with that. And then we'll have a few minutes to discuss, have some Q&A, test out maybe some messages. I want to say first and foremost, I will be happy to share all of these slides, so please don't feel like you have to write anything down. I'm going to be showing you lots of communication tactics and strategies, and I don't expect you to remember them. I'm happy to make these available. I want to say first and foremost, thank you. The work that y'all do matters so much. I've been studying cancer communication for about 20 years from the perspective of patients and families and caregivers and healthcare professionals of all walks of life. And what you do is such hard work and such important work. Like Kat said, it's a lot. One of the questions that I'll ask you to reflect on, and again, please feel free to trade ideas in the chat or just mull this over. Have you ever had a conversation or an encounter and said to yourself afterwards, man, that felt like a lot of work? If you're nodding or thinking yes, then your experience is consistent with our research, which is that the communication component of what you do is an incredibly challenging layer to all of the other work that you do, the technical proficiency, the procedures, the diagnostic work, the intellect that you bring. And then, oh, by the way, everybody wants you to have these incredible interpersonal skills. And that's a big ask. That's a big ask for anyone. And when we think of all of the things that you're being asked to do already, it's not a personal failing if these conversations are challenging. We are living through trauma upon trauma upon trauma. People are experiencing burnout. People are experiencing moral injury in the sense of betrayal that their system of employment and their healthcare system is letting them down. And they're right. We're right. We can't solve all of those, but no failure is completely personal. Having said that, there are things we can do, right? So we've been teaching communication in the communication discipline since ancient Greece, and we were teaching people to engage in public speaking. And now we teach people to have conversations in ways that are uplifting for everyone involved and successful in exchanging information and preserving valued identities and relationships. There are things we can do. If you've experienced this, I would love some examples in the chat. Yes, it can be exhausting. Yeah, that word comes up a lot in our research. So how can we cope? I teach a graduate seminar on stress and coping. So I talk about stress and coping all the time. Building on what Kat was sharing, self-awareness is so important. Self-care and self-compassion. Part of the challenge is if we don't recognize our own emotional states and our own triggers and what we are bringing into the room and that space that Kat was describing, holding that space for others, it is hard when the space is already crowded by our own sense of overwhelm, right? The idea of name it to tame it so that you know, this is what I'm bringing into the room and into the space, and this is why it's making it hard for me to carry out the work that I need to do. I hear self-care and I think, oh my gosh, I'm going to have to go to another workshop, right? Like the one that I don't want to go to, not this one, the one that I don't want to sign up for. And I don't want to give you that sense that this is just one more thing to do. My hope is that this will offer a sense of reassurance that this can be managed, but it does require us all to have some compassion for ourselves. One of the world's leading expert on self-compassion works here at UT Austin, and their research has indicated overwhelmingly that, when we don't blame ourselves and when we're kind and understanding to ourselves, or when things don't go perfectly and when we have moments of pain and failure, we have better mental health. And like y'all were saying in the chat earlier, we give ourselves grace, and it really does correlate with good outcomes for us and for the people we are serving. When we remember those past successes, that helps us to be stronger and more resilient. We've done this before, right? Some days we've done it better than others. Supporting others and reaching out and being part of this community is another way for us to take care of ourselves and to feel strengthened and empowered. And many of you may practice trauma-informed care and use trauma-informed approaches in your work. I offer the suggestion that we need to use trauma-informed approaches with ourselves too, right? So it's the idea of asking, what has happened to us? What has happened to you? What has happened to someone? Rather than what's wrong with me, right? What's wrong with them? What's wrong with this person? Understanding what has happened to bring us to this place where this is really exhausting and challenging. And this is the 36th person that Kat is having this conversation with today. So my next question is, how have you seen some of these coping strategies or used some of these coping strategies? If you want to offer some of those in the chat, I think that would be instructive for all of us. I'll build on what Kat was sharing and what many of y'all already probably do and give it some, nerdy scholarly names and ground it in the evidence base that I read and write and contribute to and teach and things like that. When we're trying to organize some of these communication strategies, active listening already got mentioned, right, in the chat, that one of the things we want to do is listen more than we talk. And that can be hard because we want to fix things, but we know we can't, and we don't have to fix everything. And I hope that is, again, a sense of reassurance that we can listen, and as Kat said, hold space and be there. And that listening is so helpful, that validating, that back channeling of, yeah, that sense of tell me more. I am here for this. My colleagues and I published a piece that's called Ask, Don't Just Answered. Sometimes what is stressful about these moments and conversations is that we feel like we have to have the answers, right? Of course, you need to share the clinical information that your patients and families want. But actually, a lot of times what people really want is they want connection. So they're asking questions and they're complaining and they're worrying and they're struggling. And what we can do is not just answer their questions, but ask follow-ups. What's going on? Tell me more. I can, as Kat said, recognizing this, I can tell that you're worried. I'm here. And I'm going to show you some scripted examples of how you might be able to work some of those in. The research has shown for decades that the best comforting happens because we have asked people questions that empower them to reappraise the situation themselves and do their own sense making. We don't have to give them the narrative. We can ask them to share with us, and through the talk, they're able to cognitively organize the information and get closer to where they need to be emotionally and healing. My colleague, David Ring, who's a hand surgeon here at our med school and cares deeply about communication and has written extensively about it, uses this term, soothe, not solve. That, sometimes what clinicians really need to be doing in the moment is soothing so that we can get to the solving and the solutions. And David always says, people don't care about what you know until they know that you care. And I really appreciate that frame. As Kat said, performing those different empathies is really important for the people that you are interacting with, as well as for your own self-preservation. And I've taught healthcare professionals and pre-health profession students from undergrad all the way through to the chairs of surgical departments. And sometimes it hits a little strangely and people say, well, I don't want to fake it. I don't want to just perform. And I'm here hopefully as a scholarly source of reassurance that performing empathy is still connecting. It's still being human. But it's not allowing yourself to be an emotional dumping ground, quite frankly, right? It's not asking yourself to dig that deeply. It's recognizing and communicating and showing people that you understand and care. And that is an important strategy, as Kat mentioned. I'm also going to talk about a strategy called affirm and then redirect, which Kat started to touch on, the idea that you're running out of time and there's a lot to cover and you kind of need to get a little bit further in the encounter, the consultation. And there are some ways to do that with empathy and still with a sense of caring and connection. And all of these are really about balancing people's needs for both informational support and emotional support. They want that at the same time. How do we disentangle that? How do you build rapport and stay on task? I'm just taking a peek at the chat. If there's something that I've missed, please feel free to interrupt me, Kat. So as I said, I will share these slides. I want to give you some examples of the scripts that we have published when we are encouraging ways to connect, to move the conversation along, to really get at the heart of the matter. What is the patient concerned about? What is the spouse or the carer concerned about? People are going to ask questions and asking, what I'm curious, what makes you say that? The idea of being curious rather than judgmental is baked into so much of the emotionally supportive communication literature. And just inviting people to tell you more signals so much about how you value them and care about them and are willing to be a witness to what they are experiencing. And again, it helps to accomplish those goals of asking them the questions so that they are carrying the conversation and you don't have to do all of the communication work yourself. That's too much, right? That's not fair. And it's really not as productive, to be honest. Can you tell me more about that? I'm here to help. Is there anything I can do? Here's how to reach me. even if people don't follow up with you to ask more questions, knowing that they can, something we have seen over and over and over again in our research is that it helps people just to know that they are able to talk to you and that you want them to reach out to you. That can actually be more helpful than really following up and reaching out and asking you more questions, surprisingly enough. If any of y'all are familiar with applied improv approaches to communication, or if you are actually familiar with improv as a performer, you might be familiar with the idea of yes and. Yes and is a technique that we teach people to keep conversations going and, importantly, to validate, take what the other person brought to the conversation and move with it rather than dismissing it. I take that sort of a click up in sophistication and abstraction when I'm looking at this from a healthcare communication perspective. People will say things that might feel like a lot to deal with. You know this, you do this all the time, right? Or it's a question that's a little bit of a tangent. It's getting off task. And our strategy for managing this is affirm, then redirect. You can affirm and say, yes, thanks so much for letting me know. I'm going to write that down. I'm going to check on that. Yep, that makes sense. I hear you. Now let me ask you, right? Or so what I'd like to know next is, or here's something I'd like to bring into the conversation as well. And so it's saying yes to what you just said, and also giving you a little bit more control over the next part of the conversation. Let's talk about some next steps. As I said, I want to have some time to discuss, to have some Q&A, to trade some scripts and maybe challenge these or amplify these. I also want to share two more slides. I have another piece that I have published that I call the 12 Fundamentals of Effective Communication. And if anybody wants that, I am happy to send that to you. I cannot possibly go through that in 20 minutes, but if you're interested, I can distill some advice from that. I also want to put a plug into our Center for Health Communication here at UT. We are in the process of developing online modules that are specifically focused on communication. Our first one is available and it is free, and it is about conversations about mental health and destigmatizing communication about mental health. If anyone is interested, that is available. I am available. I'm so appreciative of your time. I'm going to stop sharing my screen and open things up to any comments, questions, opportunities to practice. Thank y'all. Kat, was there anything that came up in the chat while I was talking that?
So a couple of themes that I've seen are just how, really from a patient-centered perspective, patients wondering, there's someone who says that the doc said, I'll take care of you, not really, opening it up for questions or wondering how folks are feeling. So it sounds like people might like some insights on how to open up the conversation with the provider, right? So if the provider's feeling a little more closed down, how do they open that up a little bit? And then I did see there's another kind of a theme around silly questions, and if things that providers can do to really help open up patients if they're experiencing something that they might have some shame around or some ambiguity around, how do they open that up? So I think those two themes seem to be popping up in the chat.
Yeah. So one of the things, so I'm going to give an abstract answer to a concrete question, then try to offer some concrete strategies. One of the things that we teach our med students is we tell them, we teach you the script so you can forget it. So what that means is there are lots of different things you can say to open the conversation, to advance the conversation, to respond to something complicated. And what works for me isn't going to work for everybody else, right? So we want to try out these different scripts, and our colleagues and friends at MD Anderson who've studied communication strategies, we notice that it's helpful for people to have a toolkit and a sort of a repertoire rather than just like the one thing that they have to say all the time. it's also better to have this repertoire and sort of set to choose from rather than just having nothing, having no approach. And so what I mean by that is there are different questions, different openers, different transitions that I would encourage everybody to have their little mental file folder and figure out which ones work for you. And if that's like your sort of default, like I always ask families a question about the cafeteria and what's been going on down there, because, you know, there's this running joke at our hospital about what's served there, go with that, right? And kind of like ease in so that things feel friendly and connecting and connected. I hear and I see comments, and based on what Kat, you were sharing too, the sense that people, they aren't feeling heard, right? How do you sort of interrupt the conversation from the patient side, right? From that perspective. My honest advice is say that, right? That I feel like I'm not being heard, or I feel like I'm not explaining this very well. The reason that I would say that is it allows people, it allows you to present that as a, let's solve this together, right? Like, I feel like I could be doing better. I feel like we could all be doing better. That's my invitation. That's my invitation for you to help me and for us to connect. I agree. It's also okay to find someone that you connect better with. And I see that we are over time by 3 minutes. So I'm going to stop there. I'm going to, I'll be happy, as I said, to share any of these slides or resources with y'all. Thank you so much.
Thank you very much, Erin and Kat. The insights you were sharing made me think so much about the first time that I really ever felt heard by a provider. And it was actually a dermatologist only 5 years ago, maybe. And I've had radiation for my GI tract on my second diagnosis. And I went to the dermatologist because my treating oncologist told me that there was a chance that I would have radiation-induced, recurrence from what I went through. And I was telling the dermatologist, why I was there. I had some suspicious moles on my back, and she started asking me questions, and then started asking me more questions, and then started asking about me. And I actually stopped and I said, I've never had somebody ask me this many questions about me. And she looked at me straight in my eyes and she said, I care about you, not your skin. And I remember the feeling of feeling heard and seen. And to know that providers are working to be better at this and you're helping them is just so empowering. And, it gives me hope. This whole event represents what we wished we had when we were going through treatment. And to know that you're working so hard to make that happen is just really humbling. So my sincere gratitude to Erin and Kat for the insights you shared. We hope you'll stay with us through the next couple of days, and we'll get to see you in chat rooms. There will be a lot of time for interaction over the next couple of days. The chats have been fantastic. We encourage everybody to play around on the platform at GVCC21.com. Just get familiar with it. There's lots of sections. And if you don't have time or energy tonight, we'll start off tomorrow with some more information to get you comfortable. So I wish we could stay in this section for a lot longer. Unfortunately, we've run out of time. What I'll ask everybody to do is to please close out of this Zoom meeting and come back to the virtual platform. Again, GVCC21.com. Go to the programs and then scroll down. You'll see a view live one for our next session, which is how to approach patient and provider relationships. And wrong page on my notes. I apologize. We have two individuals that I respect tremendously leading the next session for us. Terry Cootie, who is a patient, and will go through this real life patient-provider duo conversation with Dr. C. And both of these individuals I've known for a long time and respect tremendously. They will live play this experience for us to see and ask questions and be a part of. So hope you'll join us for that shortly. And we've got 2 more days of really amazing content coming up. So thank you for starting this, making it so meaningful, and we'll see you again in more sessions.